Dr. Bob Lim?
Yeah. Okay,
Okay.
can you hear me?
Yes,
You have
thank
to
you.
allow me to start my video because I cannot view myself also. Okay. Can the administrator allow me to start my video? Yes. Okay, now you can see me. Okay. Good evening, good day, namaste, namaskar, guten tag. I am Bob Lim from Malaysia.
Dr. Bob
Today,
Lim, I'm sorry, I think you have two devices on. There's an echo in your voice.
From Malaysia. Okay, where am I actually? Can I just hello?
Dr. Bob Lim, you are using
Hello?
two devices. Kindly mute on. There is a problem.
Hello? Hello? Can you hear me?
Yes, this audio disturbance is there. Some echo is coming.
There is some interruption.
Yes, please proceed, doctor. Please proceed. Dr. Bob Lim, am I audible?
Yes.
Please proceed.
Okay.
Yeah.
Today we are talking about the subject of tumor. Tumor is a solid mass of tissue that forms when animal cells group together. Tumor can be cancerous or non-cancerous, benign or malignant. And malignant tumor can be dangerous and need to be treated immediately. Hyperplasia is the enlargement of organs or tissue caused by the increase in the reproduction rate of the cells. Neoplasia is the abnormal growth of cells, while hyperplasia is a normal form of cell growth. Well, it is an increased reproduction rate, but it won't progress to tumor, or it may progress to tumor. So we should be aware at the hyperplasia stage and seek and consult a professional homeopath to help us. Tumor in homeopathy and integrative medicine is a symptom and not the disease itself. So homeopathy, the school of homeopathy medicine have different approaches to the management of tumor. It is a completely different approach to the management of tumor by allopathic conventional medicine. So tonight will be a continual education on the management of tumor by our distinguished guest today, Dr. PARTHA Chakraborty, who is the professor in Lincoln College, University of Malaysia. So Dr. PARTHA has been a frequent visitor to Malaysia, and I've known him very well. He's a very good friend and mentor. And he has generously shared his knowledge to us Malaysians from time to time and through so many years with PPHM, which is the Homeopathy Medical Association of Malaysia. And for your information, Lincoln University College is the second university in Malaysia to offer a degree course in the Bachelor of Homeopathic Medical Science. And the first university in Malaysia to offer a BHS course in homeopathy is Cyberjaya University. So Dr. Partha has very vast experience and has treated about 200,000 cases through his years and his history in Malaysia, in India, and he had written many books and many research has done, and especially now he's following a PhD course in neuroscience. So I think Dr. Partha will share with you. It's a continuation of what he has discussed with us in the first session. This is a continuation of the second session, but you don't miss much because he's going to follow up with the slides and the video and the result of his management of homeopathy in brain tumor. So I hope I will hand over to Dr. Partha Chakraborty. Over to you, Dr. Dr. Partha Chakraborty, over to you now.
Okay. Am I audible to everybody?
Yes.
Okay. Thank you. Very good evening. I thank my friend Bob and the members and the admin of the IFPH for providing me a second opportunity to speak on this subject. As homeopath, we don't have the choice to choose much among the patients. You know, everybody. We have to see all sorts of patients. And some of us have some knack or some specialty or some interest in some diseases. I'm having an interest in these neurological cases, and of late in my practice, I've been seeing these cases. My journey with brain tumor started in the year 2003. I shared one video in the last session. Those who have attended the last session on 14th of June, I was fortunate to have shared with you one acute phase of that brain tumor. And my interest began at that time. And till today, I've been seeing different cases of brain tumors. So over here, I'll just try to share my small knowledge of brain tumors and managing them with our homeopathic remedies. How do we manage the cases? Because just listening to brain tumor, this word brain tumor, creates a panic reaction in everybody. It used to create a panic reaction in myself, and I'm quite sure that it creates a panic reaction in everybody. So I thought that I must take up this challenge so that I can share and disseminate some of my experience that I've gained over the years. So I begin my presentation today. Last session we had on 14th of June, we discussed these points. Those who are present, they might have noticed these things that I discussed about these things. What is a brain tumor? The classification of brain tumors, okay, and the types of brain tumors. Classification means primary and metastatic, then cancerous and non-cancerous. Types of brain tumors, there are different types of brain tumors that we are seeing in our practice. Management, how do we manage? And I presented actually 3 cases I presented that day, but the time was very short. So I had to rush through the last 2 cases. So upon the request of my friends over here, I am presenting the 2 cases over here once again. Today, this part 2, I have divided it this way. First, I will be discussing something. This is my technique of teaching a subject. Whenever I'm teaching a subject, I try to impart some anatomical and physiological knowledge of that particular disease so that we are aware of the common symptoms of that disease. And finally, I'll come to some of the case illustrations, 2 case illustrations I will show over here. And then finally, I'll go to the question and answers. But I have to rush very fast because Bob has already warned me that you have to finish within time. Okay, I promise I'll try to do that. So the first part comprises of symptoms according to the location of the tumor. In the first phase, what I discussed about that, brain tumor or SOL, space occupying lesion, is something, an extra mass of tissue that arises inside the brain. It can be anywhere in the brain. The brain is a large area. It can happen in any area of the brain. And that typical location of the brain tumor, where it is located, the symptoms that are manifested in the patients, the symptoms with which the patient comes to us, they are totally dependent on the location of the tumor. So this thing also is a very interesting thing to know, that if the tumor is located in the frontal lobe, if the tumor is located in the occipital lobe, what are the symptoms that we can expect from the patient? We can have a fair idea if we know about these things. So this is a picture of the brain. You can see these are the different. I just remove this thing slightly. Yes. So you can see that these are the major areas of the brain. There's a cerebrum, there's a parietal lobe, there's a frontal lobe, then there's a occipital lobe, there's a cerebellum. Okay, there's a temporal lobe over here, and this is the brain stem. These are the main parts of the brain that we are having. There are different parts of the brain, but these are the main areas, and we'll be discussing about the tumors and their presentation according to the location. Yeah. So this is the brain stem. This is the brain stem. You can see the picture over here. This is the brain stem, the blue portion over here. It is actually the portion, this is the portion which connects the cerebrum, this big portion, the cerebrum, to the cerebellum and the spinal cord. So it is just like the, the Isthmus of Panama, which is linking South America and North America. So this is linking the major area of the brain, that is the cerebrum and the cerebellum, along with the spinal cord. It comprises of these areas, that is midbrain, pons, and medulla oblongata. Brainstem is responsible for vital functions like breathing, consciousness, blood pressure, heart rate, and sleep. Okay. Now, if the SOL or the tumor is located in the brainstem, what might be the possible presentation in the patient? There might be a lack of coordination in walking. While walking, he might walk, he might get, deviated to the right side, to the left side. That is called lack of coordination in walking. We see these things very often in the brain tumor patients. Double vision or visual changes, diplopia and visual changes. That is a major, symptom that we encounter in our practice. Difficulty in swallowing, dysphagia, difficulty in speaking and in closing the eyes. When they are sleeping, when they're trying to close the eyes, they will not be able to close the eyes. And finally, the dreaded symptom of seizures that can also be seen if the tumor is located in the brainstem. The next major area of our brain is the cerebellum. Cerebellum is located just in the back portion of our brain, and it plays a major role in the motor movement regulation and balance control. Now, we control our balance through two systems of our body. One is the cerebellum, another is the ear. So cerebellum being one of the major portion of our brain, if it is affected by a tumor, it will definitely have some symptoms of imbalance. It coordinates, physiologically, it coordinates our gait, how do we walk. It maintains our posture. That means if we are to stand, if we are to sit, how do we sit, how do we stand? That is dependent on the cerebellum, the function of the cerebellum. And definitely it controls the muscle tone. That is very important, muscle tone. Because we are having some remedies where we find that there is a lack of muscle tone. Example, alumina is a remedy where we find that there is a flacidity in the muscles. These are two portions. The third portion is, when the cerebellum is affected, I have to remove this thing, this is disturbing me. Yeah. When the cerebellum is affected by any tumor, we might encounter these following symptoms. That is, the patient might have trouble in walking. I have seen these cases in my life, that when the patient is asked to walk, we normally walk in a straight way, but these patients very often get deviated. So they're having trouble in walking, trouble in precise movement of the hands and legs. We are doing fine works with our hands. We are writing, we are stitching, we are using the computer, we are using the mobiles. But if cerebellum is affected, this particular function is affected. Involuntary movement of the eyes, twitching of the eyes, and vomiting and stiffness of the neck. That is also another presentation where we get tumors in the cerebellum. The next major area of the brain is the temporal lobe. This lobe is situated just behind the ears, temporal lobe. And this is one of the main areas of our brain which is responsible for visual memories. That we see, that we know. I know Bob because I've seen him in Malaysia. I've met him in Malaysia. And my brain can retain the image of Bob because my temporal lobe is working properly. That is a function of the temporal lobe. And not only they're remembering, that's not related to the visual memories, but temporal lobe is important for interpreting the visual stimulus that is coming inside our eyes. And the second function of temporal lobe is related to production of speech, and it controls the unconscious automatic reactions like appetite, thirst, etc. Now, if the temporal lobe is affected by an SOL or a brain tumor, what happens? We find the following symptoms in a patient. We might find the following symptoms in a patient, that is speech difficulties. Whenever he is speaking, he will have some sort of, some mistakes he will be making, committing mistakes. Memory problems, short and long-term memory. We find very often in our practice that the patients are complaining that my father, my mother, who is suffering from this problem, they can remember the remote memories, but they are forgetting the short memories. So these memory problems are dependent on the temporal lobe. Fear sensation, blackouts. Blackouts can happen, and strange smells. We are having some drugs in our Metromedica where there are some illusionary smells that we notice in the Metromedica. Maybe that those drugs are affecting the temporal lobe. So strange smells are often found in cases of SOL affecting the temporal lobe of our brain. This is one of the most important area of our brain, the occipital lobe, which is situated in the back of our brain. That is a visual processing area of the brain. This is a visual processing area of the brain. Whatever we are seeing, whatever we are viewing, it gets processed in the occipital region. And visual spatial processing, distance and depth perception. That means, say for example, you are going to tie a lace. You are going to tie a lace of your shoe. Now, how much you will bend downwards, how much you will put your fingers, you will take your hands downwards. This perception, this measurement entirely depends on the occipital lobe. Color determination, whether we are seeing red, blue, green, black, this color determination depends on the occipital lobe. And object and face recognition. While we go to the airport to fetch our friends, a lot of people are coming out from the airport, but we can identify our friend by just by the facial recognition. This function is entirely dependent on the occipital lobe. And if the occipital lobe is affected by any SOL or tumor, then what are the symptoms we might encounter in the patient? They are vision loss in one or both eyes. That means visual impairment. It can be total visual impairment. It can be a partial visual impairment or visual filters. Doctor, I can see the straight things, but I cannot see the lateral portion of my left eye or the right eye. These are called partial visual cuts. And we might suffer from, that person might suffer from some sort of illusions and hallucinations. These are all dependent on SOL from the occipital lobe. Parietal lobe is situated over here in this portion. This is also a very key area of our brain, which is responsible for understanding the world around, where we are, perception of our body awareness. Okay. And it receives and processes sensory inputs. If we touch a hot object, we feel that because that gets processed in the temporal lobe. If somebody exerts a pressure, we feel the pain because of the temporal lobe. The parietal lobe. So these sensory sensations, the sensory inputs are processed in the parietal lobe. And if the parietal lobe is involved with a tumor or a SOL, we can have symptoms like reading and writing problems. Reading and writing problems. Say, for example, if a teacher is affected with a brain tumor in the parietal lobe, suddenly he might write wrong things. He might make common silly mistakes. He might not be able to read some letters. He might make some common calculation mistakes. 5 plus 5, he will tell 11. These sort of things. Difficulty navigating while he's driving a car. He might have some difficulty navigating. He might not remember the exact path through which he has come. And nonetheless, he'll be having weakness in one side of the body and difficulty in understanding words. These are the features that we can notice when the patient is having problem in the, sorry, what is happening? In the parietal lobe. Now, this lobe, this frontal lobe is situated in the front of the brain. This is responsible for voluntary movement. Say, for example, I want to move. I want to write with the pen. So these are some of the voluntary movements that we are having. And these movements, they are coordinated from the frontal lobe. Higher level executive functions. That means cognitive skills like capacity to plan, organize, initiate, self-monitor, and control one's response to achieve a goal. These things are dependent on the frontal lobe. So doctors, engineers, those who are executives, managers, their frontal lobe must be functioning properly. And if that is affected by any brain tumor, we can find unsteadiness on one side of the body, or we can find weakness of one side of the body, and there might be changes in personality. Changes in personality, I have seen one case where the patient was of age of 65 years most probably, and gradually a 65-year-old person should have some sort of gravity, and suddenly it was noticed that he was acting like a child. He was wearing colorful shirts, he was going to the field to play football, he was running. So these changes in the personality was noticed in that particular person, and when the scan was done, it was found that there was a hypodense lesion in the frontal lobe. So this change in personality should aware the family members, and loss of smell. So this was the first part of my presentation, that according to the location of the brain where the tumor is located, we can have different sets of symptoms. But remember one thing, that tumors, they do not occur in the patient in a a typical way. It can happen, the two areas can be affected. It can also happen. So there can be some jumbled up of symptoms. The second part, the last part of my presentation today that I'll be finishing, is some of the case presentation. Last time I could not do it properly, so I will present with two cases today. Before that, I will discuss this thing about Dr. Hahnemann. Dr. Hahnemann has written so many years before that the physician's highest calling, his only calling, is to make the sick people healthy, to heal as it is termed. This thing is very important, to heal as it is termed. I'm teaching my students that you have to know what is to be cured in a disease. You have to know what is to be cured in a disease, because at one time when there were no investigations, the people were satisfied when the obvious symptoms were gone with the medicines. Nowadays, we are facing the challenge that not only the symptoms have to be, have to go in the patient, at the same time the lesion has to disappear. In brain tumor, we have to take care of two things. By the medicines, we have to relieve the symptoms, number one, and number two, the patients will go for the further investigation of MRI and CT scan to see whether the lesion has dissolved or not. So this is the thing that Hahnemann has told us, that you have to know what is to be healed in the patient. So for brain tumors, what is to be healed, what is to be cured in the patient? First is the symptom, and at the same time, the lesion is also to be healed with our medicines. That's a big challenge for us. So our objective in managing these cases should be to cure if possible. I've written if possible, because in all the cases, cure is not possible. And sometimes the cases are coming to us in such a stage that they reach a point of no return. So if we are having the scope, we have to cure the disturbing symptoms, the problems that the patient has presented before us, or the patient party has presented before us. Or sometimes we have to see the patients who have come after medical treatment or surgical treatment or radiation treatment. So these complications after medical or surgical treatment, they are also to be treated by us. They are also one sort of challenge that we are seeing in our practice. Very recently, I'm seeing a case, in the future, I might present this case. I'm seeing a case of a 16-year-old boy who is suffering from diffuse glioma. That's a highly cancerous tumor. And they went up to 21 cycles of radiation. And after that, suddenly the boy became very ill. And he was brought to me. Now he's sitting, he's eating, he's talking, he's using his mobiles. So these sort of cases also come to us and we have to deal with them. Secondly, our objective should be to save or prolong the life of the patient. Wherever it's possible, we have to save the life, or at least we have to prolong the life of the patient and to improve the quality of life of the patient. This should be our objective in treating the brain tumors. For effective homeopathic treatment, just remember one thing, don't panic. I've underlined this thing, don't panic, because if you are panicked, then you will make mistakes. You are more liable to make mistakes. Don't panic. Think about the case individually, what Hahnemann has told, what our forefathers has advised. Think about the cases individually. Take the case individually. Take it as a new case, entirely new case. It might happen that you have seen meningiomas, you have seen gliomas earlier, but take this case, the case that is in your hand, as a new case.
Dr. Partha, sorry to interrupt you. We have 15 minutes more to share your case.
Yeah, I'll finish the two cases.
So can you please proceed to that now? We have only 15 minutes left.
So this is the first case. The first case is about astrocytoma. A 54-year-old male was brought with these symptoms: history of sudden attack of slurring of speech, distortion, and inability to recognize persons. Was hospitalized and MRI of brain was done, and it was diagnosed as astrocytoma. This case, I remember, it came in 2016 to me. This person was a driver of a car, and he brought one patient to my clinic, and when he was returning from my clinic with that patient, suddenly he started suffering from this sort of problems. The patient party noticed these things, and that person was taken to the nearest government hospital, the Durgapur Steel Plant Hospital over here. A CT scan was done in February 2016, where the radiologist doubted that this was a case of low-grade astrocytoma. Low-grade astrocytomas can be cancerous, can be non-cancerous. Okay, so it was diagnosed as case of low-grade astrocytoma. He was advised operation, and the sons of that particular patient, they took him to another super specialty hospital where an MRI was done, and the same diagnosis was done, that is astrocytoma in the left frontoparietal region. Over here, in the left frontoparietal region, the astrocytoma was located. And you can see one thing, that the SOL was associated with perifocal edema. That means it was creating some it was increasing the intracranial tension in the brain. Now, astrocytomas are tumors growing in the star-shaped cells that is supporting the nerve cells in our brain. It can be cancerous, it can be non-cancerous. Now, the symptoms that I found in the patient was, when he was brought to me, lack of proper balance, slurring speech, difficulty, or there was a difficulty in recognition of persons. He could not identify his wife, his son. There was an incoordination of the functions. There was nausea, forgetfulness, confusion, total confusion, headache, mostly frontal region. This headache was actually a old symptom of this patient. And there was pain in the chest. Now, remember one thing, this pain in the chest was not located to the brain tumor, because this patient had a cardiac problem with hypertension. So these sort of cases, makes these cases more challenging. When you find a lesion in the brain, when you find that the patient is suffering from hypertension, he's having a cardiac problem, these complex cases are a big challenge for us. and we have to take these cases. So he was undergoing some cardiac drugs. He was taking hypertension medicine. Still, the hypertension was uncontrolled, and there was no history of any trauma to the head. So rubrics, what are the rubrics that was taken? Confusion of the mind, does not recognize anyone, cannot recognize anyone, forgetfulness. In the head, brain tumors, that was a rubric that I took. Speech was speech difficult, and in the extremities chapter, I took this thing, tottering gait. Now, why did I take these rubrics? I'll just tell you, because these rubrics are physical rubrics, but they were very strongly present in the patient. That's the reason that I took them for repertorization. This was the repertory chart, and the drugs that came, of the 9 symptoms that I selected, 6 symptoms were covered by conium, baryta, mercurius, plumbum, stramonium. I prescribed plumbum met. Normally, this plumbum met is a very good drug for brain tumors. It's my experience. I've learned from my teachers, and it's my experience also. Plumbum met 6. I give low potency plumbum met, and with the plumbum met, I gave calcarea fluor 3x, because we know that calcarea fluor has got a tendency to soften the tumor tissues. I continued it for 3 months. After 3 months, the tumor was showing improvement, and there was overall improvement in the quality of the patients. Now, in 2016 May, another CT scan was done, where I could, you can see this. This was the thing. Findings: a hypotense lesion in the left frontoparietal region, but no associated side effect. That means no perifocal edema was there, and radiologist opined that there was a response to treatment in response to the earlier CT scan. There was no perifocal edema. 2017, the next year they went for another CT scan in February, and you just notice this area. The radiologist is written over here, no residual or recurrence tumor has been noted. That means the tumor has totally regressed. The tumor has totally regressed. This is the beauty of our homeopathic prescription. If the prescription is correct, then what Hahnemann has advised, that what is to be cured in the patient, the symptoms are to be cured. At the same time, the tumor should also go away. If both are done, then we have done a big job. This was the first case patient, but unfortunately, the patient did not follow. But when he got the CT scan, the patient was not a very, he was a car driver. His income was not so good, so he did not come to me. But I kept on inquiring about him. I still now know that he is fine. There has been no recurrence till now. It has been already around 6 years. The second case is regarding solitary granuloma. I've got 5 minutes, Bob.
You have another 5 to 10 minutes left.
Okay, thank you. I'll finish this case and I'll go to question answers. So this was another SOL of brain, solitary granuloma. Granuloma means it's an SOL, space occupying lesion or cluster in the brain, which is formed in response to any infection, inflammation, or foreign objects. If there's an infection in the brain, if there's an inflammation, it can result in an SOL or a cluster of brain cells that is called granuloma. A male 25 years old came to me in November 2015, presented with headache. Mainly the headache was occipital headache over here. And since the last 2 months, it was associated with continuous nausea and occasional vomiting. This is a very common presentation we see in brain tumors, associated with continuous nausea and occasional vomiting. Nausea was aggravated after eating. There was blurred vision, and at the same time, there was photophobia. There was vertigo. Patient was in acute distress. He was having throbbing pain over here and was very sensitive to external impressions like light, noise, etc., and was associated with severe nausea. This was the main thing that the patient was telling me every time, that please relieve my headache. I could not tolerate any further. Patient was in such an acute distress that he wanted to commit suicide. He even told me that give me some medicine so that I can die. The pain was unbearable to him. He went to the allopathic doctors, to neurologists, to medicine specialists. He was hospitalized within the 2 months period time, but there was no relief. He took some homeopathic medicines also over there. And then fortunately he came to me. The modalities were aggravation of the pain on lying down. The pain was aggravated with any noise and any light. There was a past history of pneumonia, warm affections, and there was a past history of dry eczema in the left hand. Investigations, he did a CT scan of the brain in 2015 September, and the radiologist opined that it was a case of solitary granuloma. It was a solitary granuloma in the brain stem, just in the back, with edema, with dilated supratentorial ventricles. The main thing was that the granuloma was located in the brainstem with perifocal edema. You see the blood report, the total count of white blood cells was 7,900. It was normal. Neutrophil count was normal. The lymphocyte count was normal. The basophil monocyte was normal. Interestingly, the eosinophil count was, more. It was 8. It should be within 6. It's more. So I've underlined it. I'm coming to this point, why it was more. Now my prescription, the first prescription was made on 27th of November. I prescribed Theridion. When I did a normal repertorization, I found that it was indicating polycrest medicines. But I based my prescription on the abnormal sensitiveness that the patient was having. That is a nervous hyperesthesia. The nervous hyperesthesia, what is to be cured in this case? The nervous hyperesthesia, the tormenting symptom of the patient. We have to cure that thing first. Then we can go into the depth of the case. So I prescribed Theridion for this patient, the first prescription of Theridion. The symptoms of Theridion: nervous hyperesthesia, sensitive to noise, light, severe vertigo, and boric rites, where the indicated remedy does not hold long. Why? Because he had already been to homeopaths. They have prescribed several remedies like belladonna, glonoin, disorder remedies. Further investigation was done in 25th of November 2015. One MRI was done, and it was opined that it is definitely its case of granuloma, and possibly it was a case of neurocysticercosis. Neurocysticercosis, that means it's a zoonotic problem. You see, this is the MRI report. You can see on the left-hand side, the radiologist has written granulomatous lesion in the right side, possibly neurocysticercosis. So that means it was due to a parasitic infestation. It was due to a parasitic infestation. Either it was a case of Tinea solium or it was a case of Tinea saginata. It got deposited in the brain, and it was due to the infection of the parasite. It got deposited and there was a cluster of cells formed. That is known as granuloma. Now, 15th of December 2015, when he reported after almost around 1 month or 3 weeks, he told me that my headache has reduced substantially. There was only 1 incidence of headache. The headache was continuously tormenting him. Now the headache has come down. There was only 1 incidence of headache with Theridion. And on 30th December, slightly there was a change in symptom. Again, the pain started arriving in the occipitofrontal region. This way, the pain was coming from behind to front, and the pain was throbbing in nature. So now I have to change the remedy. I change it to Spigelia. Spigelia, we know that occipitofrontal region pain is very good for Spigelia and sanguinaria. So I prescribe Spigelia for this patient. Why? Because Spigelia, according to Dr. Bodik's Mathematica, Spigelia has got a marked affinity for eye, heart, and nervous systems. It is a very good remedy for neuralgia. And at the same time, if you go through Bodik very carefully, it's written the Spigelia is a very good anti-parasitic remedy. So everything is clubbed in Spigelia, whatever we are finding in this patient. And this granuloma, interestingly, was due to worms. And because of the worms, I showed you the blood report, the eosinophil count was more. Okay, so everything was interconnected and everything was related. Follow-up. In 10th of February, the patient again came to me. He was much better. But one interesting thing I noticed in this patient, that old symptoms have started reappearing. Old symptoms have started reappearing. That is itching in the hands. Itching in the hand, that was an old symptom that was starting reappearing. And I know that there was a past history of eczema in the left hand. So return of symptoms that indicated a change of remedy according to Kent's instruction. Repatriation was done. These drugs were coming, lycopodium, pulsatilla sulfur, and natramute. I prescribed lycopodium 200, a moderate potency of lycopodium. Further follow-ups was done in March, April, and May, which were uneventful, followed by placebo. And finally, this was the final result on 23rd of June 2016. This was the report of MRI. Normal study of brain. There was no granulomatous lesion found in the patient. So this is what has Hahnemann advised every time, that you have to know what is to be cured in the patient. Not only the symptoms, but also the lesion has to be cured. Okay, so this was the last slide. Thank you very much, Bob. I have kept my word. I finished within time.
Congratulations. Thank you, Professor Dr. Partha Chakraborty. This is the question and answer session now. For those who need to ask any question, please raise up their hand. Dr. Ahmad Hassan, do you want to say something?
I think
Okay,
he's
Dr.
mute.
Ahmad Hassan.
He's mute, I think.
Dr. Hassan, unmute.
Yes, sir. Good evening to all, sir. Thank you, our webinar platform, and also to our Dr. Partha Chakraborty. Very meaningful and educative webinar. Thank you very much, sir. Thank you very much. May Almighty bless you.
Thank you. Thank you.
Dr. Hubert, unmute yourself.
Okay, thank you. Thank you. Can you hear me? Doctor, please, I think that it is good to stop the share screen.
Okay. Is that okay?
Okay, sir.
Thank you.
1 minute. Sir, it was a very nice presentation. Last day was also the very simple presentation, and normally these neurological cases are very difficult to understand. But you are very simply, you demonstrated the cases in a very beautiful manner. Can you hear me, sir?
Yes, I can hear you.
What I want to I ask you, sir, one case I got a few days back. There is a paucity of gray matters. In such conditions, we can we do anything?
Yeah, actually, it depends on the age, because if the person is aged, it's quite natural that there will be some sort of atrophy in the brain. So there will be paucity of the gray matter. If that be so, I think we have to go according to the symptoms. She
is only 9 years old, but she had hydrocephalus.
Okay.
They suspected that it was hydrocephalus, and that is why the volume of the gray matter is reduced. So in such conditions, what he is having difficulty in depth perception, and her eyes are drooping. These are some of her condition, but she is very tall. Very tall.
Yes.
According to her age, it is she is very tall. In such conditions, what is your opinion? What we can do?
What I try to do in my practice is that I try to find a constitutional remedy for this type of cases. At the same time, I try to give medicines which will act on the pathological level also. For hydrocephalus, we have to give some medicines. I can give you an example. Yesterday, Dr. Beatrix was presenting one case, you remember, where she prescribed APIS. It was a very nice prescription. I sent one SMS to her also, that along the constitutional remedy, she had to give APIs just to reduce the cellulitis. So in these type of cases, we can think about giving some medicines which are very specific for hydrocephalus. In our practice, we have seen that APIs is one of the drugs. Apocyinum cannabium is another drug. These sort of drugs which are edematous drugs we can give besides the constitutional remedy that is coming for these cases. This should be my approach.
Okay, thank you, sir. If there is any chance for a regeneration of the damaged cells?
No, once the neurons, once they are damaged, there is no chance of regaining. This is only one cell in our body that does not, regenerate. Once it is destroyed, if it is not destroyed, yes, they can recover. But if it is destroyed, there is no chance of these neurons to be regenerated. There is no chance.
Thank you, sir.
Now, Dr. Beatrice Chestnut, please.
Oh.
Yes.
Good evening.
Yes. Dear Dr. Partha, thank you very much for explaining again your experience with the brain tumors. Great, congratulations. It's impressive how you present your cases and how you could be able to help these patients. I feel very, very moved inside to see that.
Yeah.
And thank you very much also to be so kind to repeat it. And to be precise, Dr. Partha, the second case with the granuloma. First, you prescribed pterinium, and later you prescribed Spigelia, which is very clear. Could you please again tell us how often which potency and how often you did repeat, just to have an idea?
Normally in these cases, I try to depend on the low potencies and the centesimal potencies, 6 or 30, max to max 200. Because if these cases, if you start with the high potencies, then there is every possibility of an aggravation. But one thing I can tell you over here, there was a person, there was a very famous doctor in Gujarat. His name was Dr. Maganbhai Desai. Many of you have heard his name. He's having a book on coma. If you happen to gather that book, that he was a very daring doctor. He used to prescribe high potencies repeatedly for this sort of cerebral cases. He saw only neurological cases, coma cases, and he has written a book on coma. And he has shown that high potencies also act. Mainly, he prescribed mercurius, ginkgum, this sort of a few drugs he used to prescribe. And he started with 1M. But I don't have that, that sort
Yes.
of. I start with low potencies. That's a
Yes.
safer option for me.
And how often you give it daily, like it was in the second
No,
case?
normally I
pterinium?
give this medicines. Yes, I give this medicines daily basis, but I dilute them in distilled water and then I prescribe. Then I give them. Okay.
It's a bit close to LM potencies, I would say.
Bit close to LM potencies. Correct.
But interesting. And how was it with Spigelia? Because the headache was very strong. You gave Spigelia afterwards, also in low potency?
Yes, Spigelia 6.
Yes. Also 6. Diluted.
6.
And once a day or twice or 3 times? How
Twice.
often? Twice
Twice
a day
a day.
diluted. And do they have to shake before they dilute again?
No, normally C potencies, I don't ask them to shake.
Okay.
My assistant who prepares the medicines, he shakes it and then he dispenses. Because this shaking thing is, it's variable. It depends on the person who is shaking the thing.
Yes. So very, very interesting. Thank you very much for the clear information, Dr. Partha.
Thank you, Dr. Beatrice, for your interesting question. The next one will be Sivanji Zain. Can you unmute yourself?
Yeah. Can you hear me, sir?
Yes.
Yes.
Yeah, Dr. Partha, thank you for such a wonderful presentation. So there are a couple of things that I would want to point out. It was just not Dr. Magan Desai who used to prescribe high potencies in brain tumors. The thing is that I have been trying to find that book. It is out of publication. It is not available anywhere. If you have a copy of it, I would really love if you can share it with all of us. And second thing is, so there is a case mentioned in N.M. Chaudhary's Materia Medica also, where he has he has mentioned that in a brain tumor case, a very high potency, which is CM, was given. And so that was one of the questions that I had put to one of my teachers earlier also, that generally we are told that pathological cases, lower potencies should be given, but not the higher ones. But I have seen that, the scene, like the really experienced doctors actually prefer higher potencies in such cases rather than going lower. So what are your thoughts on that, sir?
Yeah, actually, there are a lot of prescribers who prescribe high potencies. Even I've also prescribed. If you have attended my Shivangi, you are from the BGN, isn't it? From the radar.
No, sir. No,
Okay.
I'm not.
Okay, there's somebody from the radar who is Shivangi. Anyway.
All right.
If you have attended my first lecture on 14th of June.
I did, sir. I did.
Okay, you remember that I presented a video case.
Yes.
Of acute stupor. Now
Yeah.
that patient, when I started treating him in 2003, she had several bouts of unconsciousness when she was suffering from this brain tumor. And the first episode that I saw in her case was she was brought to my clinic fully unconscious. Okay. And frankly speaking, to admit before everybody, I was really very nervous to take this case. I insisted to the patient party that you should take her to the hospital. They insisted that no, you treat the patient. So after observing the patient, I just saw one thing, that the patient was almost unconscious, but she was erupting. There was constant eruption coming out. And I remember I was reading that Dr. Maganbhai Desai's book at that time. So I prescribed Carbovage 1M. I remember. I just put one drop in the tongue, and then I opened the bottle and I just put the bottle in front of the nose by inhalation method.
Yeah.
And believe me, after 10 minutes or 12 minutes, the patient took a deep sigh. There was a big eruption, and then she opened the eyes. And after 15 minutes, she went out of my clinic just by walking.
Oh, okay.
So, yes. Okay. In these acute conditions, in these acute exacerbations, you can definitely give high potencies, but you have to be very confident about the action.
Okay, thank you, sir. So I would also like to mention, so I had a case of a patient who was a 20-year-old, and he came with hypertension. He was on antihypertensives for a couple of years, which were like 2-3 years. He was told that it is essential hypertension, and something was not right. When I was seeing that patient, he was talking to me, and he was moving his hands, and suddenly I noticed that his hands were a little more than what the size should be. So ultimately, it turned out to be a pituitary macroadenoma. So it was picked up at a very early age. The endocrinologist was pretty surprised that it is very difficult to pick up these tumors. So I started initially because I was not very sure, what was happening with him. I started him on aconite, 200 repeatedly, which really brought down his hypertension. But aconite being, and he was very anxious, and all the aconite symptoms were there, really helping him out. But unfortunately, COVID started, and I lost the patient to follow up. And I mean, in the sense, and the patient is fine now. He has come back. He underwent surgery, but his hypertension is still not,
Please, we have limited time. Please conclude. Yes, please.
Yeah.
Dr. Dipanji, please unmute yourself.
No, so I just wanted to I thought of going to a higher potency. That is what I wanted to say. Anyways, thank you.
Very nice prescription.
Okay, Dr. Dipanji, please unmute yourself.
Yes, good evening, and thank you very much for such a wonderful sharing. And just I want to discuss that yes, incidentally there is one case of granuloma with me also. There is one patient, almost the same age group which the doctor has mentioned, and I gave him of course Lycopodium 6 and Spagylia. Now the thing is, I just want incidentally the prescription is also the similar one, okay, and I just want to know that how the this water doses should be given in this case.
better you can, what I'm doing, better you can just divide it into 16 doses. Depending on the intensity of the case, you can give daily doses or you can give alternate days doses or twice daily. It depends on the, the susceptibility of the patient, the intensity of the case. Okay. I think single or BD is enough, not more than that.
Yeah, of course, I'm already giving BD. But the thing is that, can you explain that how it should be given, like in the procedure that the 2 or 3 drops should be given in half glass of water, and it should be given twice a day, and then it should be discarded like that on the same day?
I don't follow that method actually. To be very frank enough, I dissolve 1 dose in distilled water. And for these constitutional drugs like lycopodium, these deep acting drugs, what I do, I divide it into 4 marks, and I tell the patient to take 2 marks twice daily for 2 days. 2 days. So that's how I prescribe the constitutional remedy. And then in your case, I would have done lycopodium for 2 days, followed by spigellia.
Okay, we have to stop here
Okay.
because the time is running
Thank
out,
you
and I
so
will
much.
invite Dr. Manoj to close the session and say the word of thanks. Dr. Manoj.
Yes. Thank you, Dr. Boblin, for nicely moderating session. So it's a nice presentation, and it must open the eyes of those who are always asking evidence. It's a perfect evidence that living human beings are the real evidence as far as homeopathy is concerned. So nice presentation, wonderful one too. So please continue to participate in IFPH platforms. Dr. Partha Chakraborty, on behalf of IFPH, I am expressing sincere thanks to Dr. Partha Chakraborty and all those who participate in the program. Thank you.
Thank you very much.
Dr. Boblin.